Good evening, everyone, and welcome to the International Myeloma Foundation's webinar, Making Sense of Myeloma Tests and Results. I'm Robin Toohey, Senior Director of Support Groups for the International Myeloma Foundation. Tonight's program is part of the IMF's Living Well with Myeloma series, which is designed to cover all the important and most up-to-date information regarding myeloma to help you live well. I'd like to thank our sponsors for their support of tonight's call, Celgene, Janssen Pharmaceuticals, and Takeda Oncology. It's now my pleasure to introduce tonight's speakers. Debbie Birns is the IMF medical editor. She started as the IMF's first official hotline specialist, and she is now the IMF's medical editor overseeing and writing the scientific content of Myeloma Today and composing many other IMF publications, including the booklets in the Understanding series. We're also very pleased tonight to have a special guest speaker, Dr. Rafat Abonour from Indiana University Simon Cancer Center. Dr. Abonour is a consultant for the IMF, and he is also part of the IMF's International Myeloma Working Group, and he will be available to take your questions tonight. And it's now my pleasure to turn tonight's call over to Debbie Birns and Dr. Abonour. Debbie?
Thank you, Robin, and thank you, Dr. Abonour, for helping out. This is going to be a quick tour through a lot of tests, so hang on tight. The information is designed for patients and caregivers to help them understand why certain tests are done and what they tell us. I'll begin with some general precautions and suggestions. First of all, what can tests tell us? Well, for one thing, a diagnosis. Is this myeloma or a precursor to myeloma, either monoclonal gammopathy of undetermined significance, better known as MGUS, or smoldering myeloma, abbreviated SMM. What is the risk of progression to myeloma? If you have one of the precursors to myeloma, what is your risk of actually progressing to active myeloma? What are the type and stage of the myeloma? The type of myeloma depends on the type of heavy chain and light chain antibody, or immunoglobulin, that the myeloma cells are secreting. Stage tells us about disease prognosis. How will the myeloma behave based on the presence, absence, or amount of certain measurable factors? Are there genetic risk factors? One of these factors to assess risk is the presence or absence of genetic mutations in the myeloma cells that can influence disease behavior. Is the treatment working? Is your myeloma worse than, better than, or the same as where you were when you started treatment? Are treatments causing side effects? For example, we can often see the effects of a treatment if it lowers the blood cell counts. And finally, how deep is the response to therapy? For example, are the bones and kidneys improving? Are there a normal number of plasma cells in the bone marrow? Are immunoglobulin levels back to normal? Immunoglobulin, by the way, is medical speak for antibody. No single test tells the whole story. Each test is a piece of a puzzle that must be assembled to understand what's going on. Don't compare test results with other patients. Myeloma is unique in every patient. Two patients may, for example, have the same type and amount of monoclonal protein, yet one of them may be very ill while the other has minimal disease and is doing very well. Many of you can go online to see your test results. Make sure you're looking at the test your oncologist ordered. This webinar should help you identify which tests are for assessing myeloma and which tests may be for other conditions, because they won't be mentioned. Always discuss your test results with the doctor who is treating you. The oncologist who's treating your myeloma will be able to put all the puzzle pieces together and put everything in context for you, because he or she knows all the details about your myeloma and your treatment history. Patterns of results viewed over time are more meaningful than any single test result in isolation. Always request or print out and save copies of your test results. You should bring a summary of your test results with you when you and your oncologist are figuring out what to do next, or when you see another doctor for a second opinion. For some patients, certain tests are more important than others. Myeloma is different in every patient. Which tests tell you most about your myeloma may depend on certain features of your disease. More caveats. Normal lab values vary from lab to lab. They are given as a range from the lower limit of normal to the upper limit of normal in parentheses, usually on your lab report next to your results. This gives you a way to compare your results with what is the expected range for healthy individuals. Test results can also vary from lab to lab. Variations in results from different labs can be caused by differences in lab equipment or in human interpretation for tests that aren't fully automated. Factors having nothing to do with myeloma that can affect test results include medicines or supplements that you take, caffeinated beverages or alcohol you may have consumed, beef consumption, stress, or strenuous exercise. Be sure to find out if there are any restrictions on diet or activities before you go to the lab. The units on lab values may also vary from lab to lab. If there's a big difference between your current test and your last test, make sure you check the units on your lab results to see if they're the same as your last test. Sometimes doctors change labs or use more than one lab. There's no time like the present to become comfortable with that good old decimal system if you're not already comfortable. 6 grams of monoclonal protein equals 6,000 milligrams, 1,000th of a gram. 1 liter equals 10 deciliters. You need to be able to do the math and move your decimal point correctly if the units switch. Because this is so important, I'll say once again that you must get and keep copies of your test results. You'll want to keep the copies of your test results to see patterns over time. Save these results on your computer and copy them onto a flash drive. There are 3 major types of tests for myeloma listed on this slide. Lab tests to assess substances in the blood and or urine, tests done on bone marrow samples, and imaging studies. I've broken down the tests that in the top category, blood and urine, which are very numerous, into smaller groups by categories. Tests that assess kidney function, tests that assess blood proteins other than monoclonal protein and other substances in the blood, and the very important group of tests that are used to assess monoclonal protein. Our first puzzle piece is a very common test. It's used as part of a healthy checkup with your primary care physician and is used throughout the myeloma disease course. It's the complete blood count, or CBC. The graphic here shows you a typical lab report for the CBC. The CBC gives us information about the number and characteristics of red blood cells, which carry oxygen to our tissues and organs, white blood cells, which make up our immune system, and platelets, which clot the blood after an injury. A note about units. I've provided the Mayo Laboratory lab units for each test I will discuss this evening. You can see on this test right next to RBC, WBC, and platelets, it has a number. For RBC, it's 10 to the 12th per liter, or billions of cells per liter of blood. So for every test I'm going to talk about tonight, there are units listed that are used by the Mayo Lab. The Mayo Lab is an international reference laboratory. Any doctor around the world can send samples there for analysis. Your lab may not use the Mayo Lab units. In fact, the sample CBC report I put on this slide doesn't use Mayo units. You can see for white blood cells, if you look across the line, the very right side, it says 4.5 to 11.0, which is the normal range, lower limit of normal to upper limit of normal. And then it says K/UL, which stands for thousands per microliter. The U looks like the Greek letter mu, so they substitute it because they don't have Greek on their computer. But it is equivalent to the Mayo units, it's just expressed differently. The 4 columns on this lab report are, from left to right, first column, the cell types and characteristics, the patient's result in numbers, third column, an indication of whether the result is L for low, left blank for normal, or H for high compared to those normal ranges, and 4, the range of normal values from the lower limit of normal to the higher limit of normal, with the units used for each test. To understand why the CBC is important, you have to understand a bit about myeloma. My apologies to those of you who already know this, but please bear with me on behalf of those who don't. Myeloma grows in the bone marrow where our blood cells are made. Too many myeloma cells can lower the blood cell counts. If there are too few red blood cells, then low hemoglobin, also known as anemia, results. Anemia is often an early sign of myeloma and is the A in the diagnostic CRAB criteria for myeloma. Myeloma is actually a cancer of white blood cells, of a certain white blood cell, an immune system cell called a B lymphocyte or B cell that develops into a plasma cell. The plasma cell's job is to make antibodies against substances that invade our bodies. When there are cancerous plasma cells, we call them myeloma cells, in the bone marrow, the whole immune system goes out of whack, lowering the immune response. Low levels of white blood cells called neutrophils, which target bacteria and fungi, can lead to increased risk of infection. Low levels of white blood cells called lymphocytes can lead to reduced ability to make antibodies and killer cells to target other foreign substances in the body. Many treatments for myeloma can also lower neutrophils and lymphocytes. You see my little down arrows there. I hope you do. They're showing up kind of funny on the slide, but they are supposed to be down arrows. The IMiDs, Revlimid, Pomalyst, and thalidomide, immunomodulatory drugs, IMiDs for short, can lower the neutrophil count, while steroids like dexamethasone can lower the lymphocyte count. The treatments, Velcade, Kyprolis, and Ninlaro, all of which are in the drug class called proteasome inhibitors, can lower the platelet count. Our next puzzle pieces are blood tests in the metabolic panel that assess kidney function. Kidneys can be damaged by light chain monoclonal protein or by high blood calcium levels that result from the breakdown of bones. Kidney-related and medical speak is the word renal. Tests of kidney function establish the R for renal in the CRAB diagnostic criteria. Serum is the clear part of the blood when all the blood cells are taken out. Creatinine is the waste product from normal muscle breakdown. When kidney function is impaired, the kidneys cannot rid the body efficiently of creatinine, and its level builds up in the blood. Creatinine clearance testing uses both a blood sample and urine from your beloved 24-hour urine collection. It is more accurate than serum creatinine measurement and is the International Myeloma Working Group, or IMWG's, preferred test for establishing the R part of the CRAB criteria. Remember that while the level of creatinine in the blood increases with kidney damage, the clearance of creatinine from the body is decreased with kidney damage. The glomeruli are the basic filtration units of the kidney. The IMWG diagnostic criteria use estimated glomerular filtration rate, or eGFR for short, to determine the R for renal in the CRAB criteria rather than serum creatinine level because it is a more reliable measure. It's calculated automatically as part of the creatinine clearance test. You'll notice that it is expressed as an estimation of how many milliliters of creatinine are cleared per minute per square meter of your body mass. Blood urea nitrogen, or BUN, or BUN, is a measurement of the waste product that accumulates in the blood when the body breaks down proteins. The amount of blood urea nitrogen increases when the kidneys or liver are damaged. Our next series of puzzle pieces are tests used to measure certain proteins and other substances in the blood that are part of the blood chemistry panel, also called the metabolic panel. The panel of tests, like the CBC, is also part of a basic medical exam, so while these tests can tell us about how the myeloma is behaving, they are not specific for myeloma and are also used for other medical conditions. Elevated blood calcium, or hypercalcemia, is the C in the CRAB diagnostic criteria. Calcium is released into the blood by bone breakdown. Hypercalcemia can cause kidney damage. Bisphosphonate therapy with Zometa to prevent bone breakdown is also a treatment for hypercalcemia. The total protein test measures all the proteins in the blood, which fall into one of two types, either globulin or albumin. Globulin is antibody protein, so it is therefore increased when myeloma cells are making monoclonal protein, which is a globulin. Albumin is made in the liver and is excreted by the kidneys. Changes in the amount of albumin are not related to myeloma, but can indicate liver or kidney disease. Albumin is the most abundant protein in the blood. Neither serum beta-2 microglobulin nor lactate dehydrogenase level is a test used only for myeloma, but high SB2M SB2M is elevated when myeloma is active. High SB2M indicates more active and aggressive disease. The same is true for LDH. Both SB2M and LDH are used in the staging system for myeloma. SB2M is in the International Staging System, or ISS, and LDH is part of the revised ISS, or RISS. Elevated C-reactive protein is a marker of inflammation. CRP testing is probably used most commonly in the context of heart disease, but many diseases other than heart disease can cause increased CRP, including cancer, infection, and autoimmune conditions such as rheumatoid arthritis, lupus, and irritable bowel syndrome. In a myeloma patient, increased CRP can signal active disease. CRP is produced in the liver in response to inflammation. Our next test is used to measure blood glucose, or blood sugar. The level of blood glucose should be monitored carefully in all patients taking a steroid such as dexamethasone, which can raise the blood glucose level. Our next group of blood and urine tests are very important because they are used specifically for assessing myeloma. They all measure the output of myeloma cells, monoclonal protein, in the blood and/or urine. Serum protein electrophoresis, known by its acronym SPEP, is a test that separates all the proteins in the blood according to their electrical charge. Urine protein electrophoresis, or UPEP, does the same thing for proteins in the urine. The upper graph on this slide represents a normal SPEP result. It shows a peak in the measurement of albumin, which you'll remember is the most plentiful protein in the blood, and lower levels of the other proteins grouped into areas labeled alpha 1 and 2, beta with 2 bumps, also known as 1 and 2 that aren't labeled here, and gamma, which is where the antibody proteins, including those made by myeloma cells, would lie on the graph. The lower graph represents the result for a patient with myeloma. In addition to the spike for albumin, we see another tall spike indicated by the red arrow in the gamma region of the graph. The area under that spike or curve can be measured. The pathologist measures the area under that curve and then subtracts the normal level of gamma globulins from that total. And that is your level of monoclonal protein, also known as M protein, made by the myeloma cells. SPEP and UPEP tell us how much monoclonal protein there is, but not the type. Remember that monoclonal protein is the output of myeloma cells in most people with myeloma, but every person's myeloma is unique to them. The output can vary in amount from patient to patient and can vary in how that amount relates to the behavior of the myeloma. SPEP and UPEP are an indirect measurement of how the myeloma cells are behaving, and not every person's myeloma cells behave in the same way or reproduce at the same rate. Some other issues with SPEP. Immunoglobulin A, or IgA-type myeloma monoclonal protein, does not separate out in the gamma region of the graph, but can get stuck with the beta or even alpha proteins. Patients with IgA heavy chain myeloma usually do better using a different test to assess how much IgA they're making. Another issue is that treatment with Darzalex, also known by its generic name, daratumumab, can very slightly increase the M spike, but only in patients who have IgG kappa myeloma. The Darzalex is made out of IgG kappa monoclonal protein. This is only a problem for patients with IgG myeloma who are being assessed for complete response after treatment with Darzalex. An experienced pathologist is usually able to determine if this small amount of immunoglobulin protein is the Darzalex itself, which is a monoclonal antibody, or is residual myeloma. If there's any question, a blood sample can be sent by the doctor to Janssen, the maker of Darzalex, for further testing. Immuno Fixation electrophoresis of blood or urine is the counterpart to SPEP and UPEP. IFE tells us the type of monoclonal protein in the blood and or urine, but not the amount, while SPEP and UPEP tell us the amount, but not the type. The result of the IFE is that a certain type of monoclonal protein is either there or not there. Like UPEP and SPEP, IFE also separates proteins by electrical charge, but this time only the monoclonal abnormal antibody proteins are separated out, not the normal ones. As with SPEP, Darzalex can influence the result of IFE if a patient has IgG kappa myeloma and is being evaluated for complete response. The patient may be in a very deep complete response, but a tiny band of IgG kappa will show up on the test readout. If the pathologist is unable to make a determination whether the band is from IgG kappa myeloma or from Darzalex, Janssen will do so. Quantitative immunoglobulin testing, or QIG, is done to see if any of the 5 immunoglobulins are abnormally high or low. In myeloma, one type may be high while the others are low, because remember, your immune response is suppressed, so your normal immunoglobulins are usually a bit lower if your myeloma is active and you're secreting a certain type of monoclonal protein. QIG measures the total of each heavy chain antibody type in the blood: IgG, immunoglobulin G, IgA, IgM, IgD, and IgE. Most myeloma patients have either IgG or IgA myeloma. Quantitative immunoglobulins measures both normal immunoglobulin and abnormal immunoglobulin proteins in one lump sum. If an increase in an immunoglobulin is found, further testing with IFE is required to see if it is myeloma related. QIG is often done as part of early screening for myeloma if the total protein test from your metabolic panel result is high. QIG determines if the elevated protein is actually globulin, not albumin, and will indicate which globulin level is elevated. Some doctors also use QIG to follow patients with IgA myeloma since, as I mentioned, it's difficult to assess IgA myeloma with SPECT. Okay, here's a difficult test. Free light testing is used throughout the myeloma disease course for patients whose myeloma cells secrete free light chain protein. Most patients' myeloma cells secrete both heavy and light chains. The light chains are named either kappa or lambda after the two doctors who discovered them, whose names were Korngold kappa and Lipari lambda, which is L in Greek. Testing for free light chains in the blood before they are filtered out through the kidneys into the urine is a highly accurate and sensitive test. On the slide, you see the blue and pink Y-shaped structure of the intact immunoglobulin protein, blue heavy chains with pink light chains bound to them. Much of the time, in healthy individuals and in myeloma patients, there are extra light chains that are not attached to heavy chains. They are called free light chains, and I have no idea why we make them. Some patients' myeloma cells only secrete light chain protein and no heavy chains, and some myeloma patient cells secrete so little monoclonal protein at all that only the very sensitive free light test can be used to measure it. So free light is an especially useful test. It is useful for almost all myeloma patients for diagnosis, prognosis, and monitoring response to therapy. It's used to monitor early relapse during remission periods as well. This is an inexpensive and widely available test, not to be confused by your doctor with an older test called kappa/lambda light chain, total, serum. That test has a different code than the free light test. It measures both bound and unbound light chains, while the free light test measures only the unbound or free light chain. Sometimes a doctor will inadvertently check off the wrong test on the lab request form, and your results will cause you concern, and you will call the info line. Make sure you're getting the free light chain assay or free light test. That's the brand name. Free light testing measures the involved free light chains that are made by myeloma cells, as well as the uninvolved free light chains that are made by normal plasma cells that we all have. We all have some freely circulating normal light chain antibodies in our blood at any given time. The ratio of kappa to lambda helps determine if there are too many light chains of one kind or another, indicating myeloma. If the number of kappa and lambda light chains are both high, but the ratio between them is within the normal range, it indicates a kidney problem, not myeloma. The ratio, as you can see, is calculated by doing a division problem. You divide the number of kappa chains by the number of lambda chains. The heavy light assay is a blood test that measures the intact immunoglobulins, like those you saw in the picture with the blue and the pink, with light chains bound to heavy chains. Not only does it measure the intact heavy and light chain protein made by the myeloma cells, it also measures the heavy and light chain bound immunoglobulin protein made by normal plasma cells. If your myeloma protein is, for example, IgA kappa, the heavy plus light chain intact immunoglobulin that is its normal counterpart will be IgA lambda. IgA-bound IgA lambda chains are going to be your normal healthy ones, and the IgA kappa ones are your myeloma chains, immunoglobulins. IgA kappa is thus paired with IgA lambda. If the intact immunoglobulin involved in your myeloma is high, the heavy light test will show that. The heavy light test will also show that that uninvolved intact immunoglobulin paired with your myeloma and made by normal plasma cells is low, because when you have active myeloma, your ability to make normal antibodies is decreased. The test is often used to measure IgA heavy chain protein because IgA, I will repeat, is sometimes difficult, or just plain old difficult to assess with SPEP. Our next set of studies are studies that are done on bone marrow samples. Remember that myeloma usually grows inside the bone marrow. Bone marrow aspiration is done with a syringe which draws out the liquid part of the marrow. A core biopsy is done with a special hollow needle, and it captures a sample of the spongy bone in the marrow along with its contents. This is an uncomfortable and painful study. I don't have to remind you of that. So there are no strict rules for how often it must be performed. It's the only eyes-on study of the myeloma cells under a microscope. All other tests rely on indirect markers of what myeloma cells are doing. The pathologist who looks at your myeloma cells under the microscope writes a report detailing how many of the cells in the sample are abnormal plasma cells and what they look like. Words like mature, immature, and atypical may appear in your report. Immunophenotyping is done by flow cytometry. It identifies protein markers on the surface of myeloma cells. It is used to determine both stringent complete response and minimal residual disease, known as MRD, which is even less myeloma than stringent complete response. The IMS Black Swan Research Initiative funded Next Generation Flow Test was developed especially to detect minimal residual disease and is sensitive enough to detect one myeloma cell among every 1 million plasma cells sampled from the bone marrow. The next two slides cover bone marrow tests of chromosomes and the genes on them. Standard cytogenetics is an old test. It is used to observe what happens to the chromosome in a cell's nucleus during cell division. It's also called karyotyping because a karyotype is the number and appearance of chromosomes in a cell's nucleus. Loss of chromosome 13 during cell division can be detected better with cytogenetics than with the next test I'll discuss called FISH. Loss of chromosome 13 is usually an indication that other genetic abnormalities are present in the myeloma cells. Fluorescent in situ hybridization is FISH. Neither cytogenetics nor FISH gives us complete information by itself, so they are often both done. In FISH testing, each chromosome is identified by different color. If we see a small section of one color within a chromosome of another color, we know that a segment of genes from one chromosome got mixed in with another chromosome during cell division. If part of a chromosome is missing, that's visible too. The pathologist can identify those translocations, the movement of little pieces of one chromosome to another, or deletions of genetic material from the chromosomes that are known to be high risk in myeloma, such as translocation 414, which means pieces of chromosome 4 are in chromosome 14, or deletion 17p. Deletion 17p is the loss of the short top part of chromosome 17, where a major tumor suppressor gene called p53 is located. You don't want to lose a tumor suppressor gene. Those myelomas are, it's not something you have control over, of course, but that is a high-risk mutation. The final pieces of our puzzle are imaging studies. Among other things, imaging studies are used to assess bones, the B and the CRAB diagnostic criteria. Bone disease in myeloma is always related to bone loss. Our first and oldest imaging study is the X-ray or skeletal survey. X-rays are simple and inexpensive studies, but in addition to exposing patients to radiation, they're not particularly sensitive and are not useful for diagnosing early disease. You have to have lost 30% of the hard outer part of the bone before an X-ray will show bone damage. X-rays do not show early abnormal areas in the bone marrow called focal lesions. In the graphic on this slide, you can see the loss of the hard outer bone that we call a lytic lesion, as well as the massing of myeloma cells within the bone marrow that does not appear on an X-ray. X-rays also do not show bone healing in places where there is no longer active myeloma, so X-rays are not useful for monitoring response to treatment. MRI, magnetic resonance imaging, uses magnetic energy, not radiation. That's a good thing for patients. It is highly sensitive for the detection of early bone marrow involvement, those focal lesions you saw on the picture, before bone destruction actually occurs. MRI can distinguish between benign and malignant vertebral fractures. A benign vertebral fracture is one caused by osteoporosis, which is common in older women, for example. MRI can detect spinal cord compression and soft tissue masses, which are usually called, in myeloma, plasmacytomas. They're masses of cancerous plasma cells. MRI is not good for monitoring because it takes up to 9 months for healing to show up on an MRI. So if you're comparing a new MRI to an old one, within those 9 months, you may not see any sign that there's no myeloma there anymore, even though there really isn't. MRI may require the contrast agent gadolinium, and that can be a problem. Gadolinium contrast we've always known, might be harmful to myeloma patients with kidney damage. But on Friday of last week, a committee set up by the Food and Drug Administration voted to recommend a new warning for gadolinium-based contrast agents used in MRI for everybody. The FDA asked the committee for advice on how to weigh recent findings of gadolinium retention in the brain and other organs and how to minimize potential risks moving forward. Please discuss the use of gadolinium contrast with your oncologist before she or he sends you for an MRI with contrast, particularly if you already have kidney issues. Request that the study be done without contrast. Computerized axial tomography, or CT, which used to be known as a CAT scan when I was young, is a cross-sectional three-dimensional X-ray. It's more sensitive than X-ray for small lesions and for those soft tissue masses. It does expose patients to radiation, although there's a technique called low-dose CT that obviously exposes patients to less radiation. It is not good for monitoring because the appearance of lytic lesions, the loss of that hard part of the bone, may not change even if there is no longer active myeloma. And again, although it's not with gadolinium, CT may require contrast agents that pose problems for those patients with kidney damage. PET, or positron emission tomography, is a whole body real-time study. It means that the radiologist can see where the myeloma is actively growing in the body at the moment the test is being done, because those areas where there are active myeloma cells light up. It's very useful when a patient has non-secreting myeloma cells that make no monoclonal protein, because if the myeloma cells don't secrete monoclonal protein, you need something other than bone marrow biopsy to help monitor the disease. A PET-CT is a PET with CT only of those areas that light up on PET. Some doctors are now using PET MRI instead of PET CT for patients who require more frequent monitoring with PET in order to avoid the radiation from the CT. Of course, PET is expensive, even more so when CT or MRI is added, so all of this requires insurance approval. PET is used in diagnosis, therapy assessment, and prognosis. It shows if there is extramedullary disease, which is myeloma that grows outside the bone marrow. The need for PET scanning is included in the IMWG's consensus statement on how to assess response to treatment. PET is considered a requirement along with either next-generation flow or next-generation DNA sequencing in order to assess minimal residual disease, because both of those studies are based on bone marrow samples. Sometimes myeloma is extramedullary, meaning that it grows outside the bone marrow. PET imaging will pick up areas where myeloma is growing both inside and outside the bone marrow. So here's our complete puzzle. You'll notice that the edges of the puzzle are not complete, but are open to still other pieces. First and foremost, there is no lab test, biopsy, or imaging study that will negate the importance of a physical exam and the observations of your treating doctor. No amount of testing will ever tell the whole story. There are so many other factors influencing the behavior and outcome of your myeloma. All the other things besides myeloma that may be going on with your body and your health will influence your myeloma disease course, including other illnesses you may have, your level of pain, your emotional state, your stress level, your support system, and whether or not you are well covered by insurance. Here are some resources for more information that you can, the two booklets we do have in the Understanding series on testing are Understanding Your Test Results, which is kind of a more detailed version of what I just spoke about, and Understanding Free Light and Heavy Light Tests, because those two tests require a booklet of their own, and it is currently being rewritten by our friend at the binding site, which makes those tests. An IMF video on EMR or electronic medical records is available on YouTube. We also have a tip card covering the important features of that video. And then we have a page on our website with information about that next generation flow test for MRD testing and other projects of the Black Swan Research Initiative. And now I will turn it over to Robin and Dr. Abonour.
Okay, thank you so much for the useful explanation of current tests and results in myeloma, Debbie. I'm sure that patients and caregivers will be able to have better conversations with the healthcare team based on this information. So we're back to the question and answer part of our webinar with Dr. Abonour. So if you have not already done so, please remember to type your question into the control panel box under questions. And as a reminder, we ask that questions be general in nature and specific to myeloma to benefit all the listeners on this webinar. And I also see that we have a few myeloma support groups that are participating on this live webinar. So a big shout out to West Bend, Wisconsin, and a few of the other groups out there that are gathering tonight. What a fantastic way to learn. So I think we'll move on to our questions now, Dr. Abonour. The first one comes from Jack, and he asks, would DARZALEX also affect MRD, minimal residual disease results, like it does IFE and SPEP?
So let's just say that DARZALEX or daratumumab is a monoclonal antibody. So it's like the myeloma protein is unique. And the subtype of that is an IgG kappa. Now, when people look for minimal residual disease, they try to find sort of specific marker for the myeloma which is not really present in the monoclonal antibody daratumumab or Daralex. So if you find in the serum protein electrophoresis in the blood this monoclonal protein IgG kappa, but you do have a specific marker, or you're doing the flow cytometry, you may not, you will overcome this confusion that having this monoclonal antibody in the blood from the infusion. So I think if you are looking for MRD, minimal residual disease, by flow cytometry or by what we call sequencing of the DNA, you will be able to detect the presence or the absence of residual disease, because you're not using the same thing as we use in serum protein electrophoresis and Immuno Fixation, looking for the type of the immunoglobulin. Now we're looking more either what's on the surface of the myeloma cells that make them unique, or what's inside the myeloma cells which making you unique, the genetic makeup. So actually, yeah, the MRD is a good way testing to sort of get rid of this confusion about this minimal, small monoclonal protein you see with the infusion of Daralex.
Okay, that's excellent. Our next question comes from Scott, and Scott asks, what tests and trials are there for aggressive smoldering myeloma?
Well, I mean, I think, yeah, that's, there are a lot of, in terms of testing for smoldering myeloma, there isn't a unique testing that we are using other than looking at the amount of monoclonal protein, the certain cytogenetics, and then come up with a high-risk profile. I think that a lot of people are sequencing smoldering myeloma to try to come up with a special profile for high-risk smoldering myeloma. In terms of trials, there are tons of trials, that will be available. With really the goal is to see if we can get more patients into minimal residual disease negative state in the smoldering high-risk myeloma in order to cure myeloma. And so if we succeed in the high-risk smoldering myeloma and we can actually get patient into MRD negative, minimal residual disease negative state for more than a year, we maybe start talking about curing myeloma.
Okay, the next question is from Chris, and the question is, are those with non-secretory myeloma only of the light chain disease type?
Can you repeat the questions again?
Sure. Are those with non-secretory myeloma only of the light chain disease type?
No. By definition, I mean, when you measure either this in serum, a monoclonal protein, in the urine, a monoclonal protein, or you have an elevated light chain by the free light chain assay, then this is a secretory myeloma. When you cannot measure anything, that will be non-secretory myeloma. And when we use the serum protein electrophoresis, the urine protein electrophoresis, and the free light chain assay, 99% of the patients will have something measurable. Unfortunately, the 1% or less who don't have anything that to measure to follow the disease, we have to depend on either the PET scan or the bone marrow biopsy.
Okay, the next question is, can you comment on the recent FDA closing or halting of myeloma immune therapy trials?
Sure, I can. Obviously, that's not the subject of the discussion tonight. But I think what happened is that the FDA noticed that there wasn't a huge difference in terms of the outcome. There weren't, large number of patients who received immune checkpoint inhibitor did well compared to the people who didn't receive checkpoint inhibitor. What they noticed also is that there were more deaths when the patient gets checkpoint inhibitor, PD-L1 inhibitor with the immunomodulatory drugs. So I think that the FDA was obviously correctly scared to see, okay, what's going on here? Why are we seeing more death? Is there more autoimmune disorder? Are we making the myeloma more aggressive? So I think we're going back to the drawing board to see what are these deaths, what are these toxicities, can we use these checkpoint inhibitor, which is really, I think, fascinating. I mean, they work well in lung cancer, they work well in melanoma and renal cell cancer. And if we can get them to work well in myeloma without causing, side effects, I think that could be amazing, because awakening the immune system to make it recognize myeloma and kill myeloma is an advantage. But I think, at this point, 2 trials showed increased mortality, death, when people get those combination of IMiD, like Pomalyst or Revlimid, with these checkpoint inhibitors. So the FDA put a clinical hold on these trials and similar trials until we figure out what's wrong. Okay?
Okay. The next question is from Alexa. What is the standard range to SPEP and UPEP?
Standard range. Standard range is not to have a monoclonal protein in the urine or the serum, so it should be 0. So when you detect the monoclonal protein, that's abnormal, and if you detect the monoclonal protein in the urine or the serum, basically you have disease. When it's gone, the disease is in remission. So there's no standard range.
Okay, next question is from Ed. How often should a patient have a PET-CT testing, and also taking into consideration the amount of radiation exposure over time?
Yeah, that's a very, very good question, and I think we're still trying to figure out how to do it. So I think in the newly diagnosed patients, when we are getting away with these simple x-rays, we call them skeletal survey, and some people are using either a whole body CT scan, whole body MRI, or a PET scan. And a PET scan, as you heard from Debbie, is a really good test when you have disease outside the bone marrow. So if you have somebody present with what we call them this tumor, the plasmacytoma, and you know that they exist in a certain way, and you want to follow up on the patients, a PET scan can be useful. So I think at diagnosis, they may be useful. As a follow-up, if you find something that you need to see if they're responding or not, or when the disease relapse and you don't know the extent of the relapse, you can do a PET scan. So I think at diagnosis, at relapse, and if there's something you cannot follow up with any other imaging, then you can do the PET scan for follow-up. Okay?
Okay, this question kind of tails on to what you just answered. Kevin would like to know, when you're relapsing, how do you measure the myeloma? What tests should you be redoing to determine restarting your treatment?
So the tests we do for relapse, so obviously you are following the monoclonal protein in the serum or the urine all the time. So if it was 0 and now it's 1 gram, then that's a relapse. If the free light chain was normal, ratio was normal, and now the free light chain is elevated and the ratio is abnormal, then this is a relapse. And so you can do and say this patient has a chemical relapse. But you also have to see if the patient has what we call symptomatic relapse. Are they having any of the CRAB criteria, high calcium, kidney dysfunction, anemia, or bone destruction? So based on the symptoms, if the patient has a new back pain, you do an MRI. If the patient has, not feeling well, you obviously need to do chemistry to check the calcium and the creatinine. So it depends on the clinical condition and what's happening with the serum test. Mm-hmm.
Okay, we have a question from Chris, who is asking for you to please comment on the new test known as the total body MRI, or DW MRI, versus PET scan.
Yeah, so I think these tests are going to, so first of all, I mean, the MRI is much more sensitive, I said, than the skeletal survey. So what you're going to see on an MRI, you're going to see the bone structure. You're going to see if there's a lesions inside the bone or outside the bone. Sometimes, you know, you can see by MRI if there's an active, you know, sort of lesion, but it's not very sensitive like the PET scan. PET scan, you use a sugar that is radioactive and is picked up by, you know, cells that multiply fast. So if you have rapidly growing myeloma, very aggressive myeloma, and the sugar is picked up by the myeloma cells, then it will light up and then you can see it. So it's a little better, but the whole body MRI is becoming a replacement to the skeletal survey to be able to see the lesion that you cannot see on a simple X-ray. Mm-hmm.
Can I add one thing here? Only, Chris, I happened to be at a subgroup meeting at the IMWG Summit on imaging, and they have proposed and are planning a big clinical trial to compare diffusion-weighted imaging MRI or DWI MRI versus PET scan, and it's going to be at centers all over the place. There were investigators there who are interested in it all over the globe. So that will be conducted in the coming year or so. So we don't have an answer on what's the best test. This is going to be done for patients who have had a stem cell transplant to monitor them before and after transplant.
Okay, I think we'll have enough time to take maybe one more question and then we'll do a little wrap up. So the last question is going to come from LaDuke, and the question is, how often should an asymptomatic, high-risk, smoldering multiple myeloma patient, otherwise healthy, how often should testing be done, like bone marrow biopsies, MRIs, 24-hour urine?
So I think the high-risk smoldering myeloma, I will follow them with blood tests or urine tests. I will not repeat the bone marrow until I see a reason for it, like, for example, they're becoming too anemic or their counts are abnormal. I would not do a routine PET scan or MRI unless there is symptoms or significant rise in the monoclonal protein. So I think just following the patient by good history, good physical exam, and a blood test is adequate.
Okay, so thank you, Debbie and Dr. Abonour, for taking the time this evening to help us make more sense of all these extensive and new myeloma tests and results. A few reminders for everyone tonight. The IMF website is a wealth of information, so I hope you're accessing it daily or weekly as you have time, and that's myeloma.org. The replay of this webinar will be available early next week, and you can access this as well as all previous IMF webinars at myeloma.org and simply click on IMF TV. A few important reminders are the last IMF Patient and Family Seminar of 2017 is in Dallas, Texas on October 6th and 7th. It's a 2-day program. And there are 3 IMF regional community workshops left this year happening in the fall. One in Charlotte, North Carolina on September 23rd. Another in Fort Wayne, Indiana on September 30th. And the last one is in Duke, North Carolina on November 11th. So don't forget, if you have questions, the IMF info line has answers, and that's 1-800-452-CURE, which is 2873. Missy, Judy, and Paul are always happy to take your calls. Our thanks to each of you for participating on this webinar tonight, and we hope you found it helpful. And once again, to Debbie Birns and Dr. Abonour, your experience and expertise is always so much appreciated. And we thank our sponsors again of Celgene, Janssen Pharmaceuticals, and Takeda Oncology. And most importantly, thanks to each one of you on this call tonight. We wish you well. Have a wonderful evening. That concludes tonight's call.